So we have a 54-year-old man, and he has been referred to you for intractable headache for the last 3 months. With the constant feeling of nausea recently, patient family also have been concerned about. They are noticed that the patient has become increasingly forgetfulness. Otherwise, he was well, except mild hypertension controlled by dietary modification. The only other important thing is he worked in the petrochemical plant for 24 years. Routine investigations are normal and negative for any underlying any infective or metabolic process. Well, imaging studies performed on the patient showed an irregularly shaped hypodense mass with a surrounding ring of cerebral edema located in the left temporal lobe. The findings were consistent with diagnosis of glioma. The clinical sign would have best localized this lesion in the temporal lobe. The answer to this question is contralateral superior homonymous hemianopia. Why this? Why not others? Well, before I proceed further, let me give you a very important clue for the question. This is the glioma, which is a type of astrocytoma. And this patient has worked in the so-called petrochemical industries, petrochemical plant. These astrocytoma are very common in those who work in the petrochemical plants. This is a very, very important point to be noted. Okay, so-called a type of occupational hazard. If they talk about what the occupational hazard in the petrochemical, that is astrocytoma. Well, now lesion in the temporal lobe that may affect Meyer's loop of the optic radiation which causes contralateral superior homonymous hemianopia or quadrantopia. Why is it so? Let's learn the basic concept without which you will not understand. A very basic concept about the eye. This is the eye field and this is the brain. Ultimately, whatever from the optic nerve, it goes to this is a field, upper field, lower field. The upper field fiber, they travel from temporal lobe and ultimately they all go to occipital lobe. We know very well the area of vision is occipital lobe. Lower field fiber, they go via parietal lobe and ultimately they go to the occipital lobe. Okay, let me give you a very simple example. Well, this is the box. This is upper box and lower box. You are watching this box, but this upper field, they are going via your temporal lobe going to occipital lobe. This lower field, this is going from your parietal lobe and ultimately it goes to occipital lobe. So obviously now if the patient has a problem in the temporal lobe, there is a tumor. It is going to compress this fiber of the radiation which is taking upper field fiber. And this lower fiber is called loop of Meyer's loop. So obviously when this tumor will be in the temporal lobe, that will lead to superior homonymous quadrantopia will be there because superior field fiber are lost. Similarly, if the patient has lesion in the parietal lobe, there will be inferior quadrantopia. Inferior field fiber will go. Okay. So, glioma account for most parenchymal tumor that we know very well. The glioma, so-called astrocytoma, are the most common tumor in the brain. And they are divided into, and they classify on the basis of histological finding and molecules are characteristic. Now these, as I told you in the very beginning, these tumors are very common, those who work in the rubber industry or petrochemical industries. Okay, and they are especially more prone to develop glioblastoma multiforme. And we all know very well that it's a grade 4 type of astrocytoma. And this is a highly malignant type of tumor. So our patient has worked in this industry for 24 years. It's quite possible that he could have developed because of this his occupational hazard, which I mentioned in the very beginning also. Well, now look into stereognosis. What is this? It is also known as tactile agnosia. Okay, it is inability to recognize, identify an object by touch. Okay, well, what you do, you must be having a pen in your hand. Okay, now what I'll do, I ask you to close the eyes, or rather you close your eyes and you keep your pen automatically in your hand like this thing. Okay, your eyes are closed and you can make out this is a pen. Of course, now you know because you yourself have kept it. Otherwise, somebody else keeps any object in your hand. By this field, you can say, okay, this is a pen, it's a coin, or it is whatever it is. This is tactile agnosia. We are able to identify by touch only. Of course, our eye is closed. Okay, so it's a type of cortical sensation which is in the parietal lobe. Now those patients who have a parietal lobe disease, they will not be able to appreciate this, and this is known as astereognosis. Well, when a patient is able to normal function, that we are able to identify anything by touch, we call as stereognosis. And when the patient is not able, then we use the term as astereognosis. So it's a type of sensory deficit in the parietal lobe pathology. Now I have a question for you. What are the other cortical sensory deficit in the parietal lobe, or rather to be more precise, which are the cortical sensation which are there, and of course parietal lobe lesion will be there, and that will lead to cortical sensory deficit. Write down the answer. What are the cortical sensory functions? Well, stereognosis is inable to recognize any object by touch. Graphesthesia, well, again, like you close the eyes and just try to write 0 on your palm with your left, yeah. So you can appreciate what has been written. Of course, this you are writing yourself. In this, we ask the patient to close the eye and we write something on the palm. Okay, the patient is able to appreciate, this is known as graphesthesia. Recognizes writing on the palm with the eyes closed. 2-point discrimination. Well, what is done, you ask the patient and you keep, of course, you take two cotton roll, this thing. Then you try to keep one place and one place. 2 point, 1, 2. The person will be able to recognize that I have been touched at 2 places. This is known as 2-point discrimination. And touch localization is again something that need to be understood very carefully. Now I tell you each one of them. First was stereognosis. By touch only the person can recognize. Graphesthesia, you have written something on the palm, patient can appreciate what has been written. 2-point discrimination. Let us say this is the forearm of the patient. Okay, you touch at one place, then you touch at other together. He will be able to appreciate that it has been touched on 2 places. In the patient of the parietal lobe, there will be contralateral loss or 2-point discrimination. He will not be able to discriminate whether touch is there at one place or other. Now we have so-called touch localization. Okay. What you do, this is the patient, one limb, one hand, this is the second hand. This is the left side, this is the right side. And he has a right-sided parietal lobe lesion. Right parietal lobe lesion. You touch here on the right side, he can appreciate. You touch here on the left side alone, he can appreciate. But if you touch together both at one place, he will not be able to appreciate this. Only he will be able to appreciate this. This is so-called touch localization. Bilateral simultaneous stimulation will be able to appreciate only on one side, not on other side. These are the 4 cortical sensory functions are done by contralateral parietal lobe. Okay, so I hope you are clear about the cortical function. Now option A, ipsilateral superior homonymous quadrantopia is not a feature, is always contralateral superior quadrantopia, the point I mentioned in the previous slides. This diadokinosis is impaired ability to perform rapid alternating movement like this thing. Okay, this we can do. Yes, you also try. Yeah, you can do it. Now, alternating movement. Okay. Now, it's a classical feature of the cerebellar disease. But sometimes it may occur in frontal lobe lesion also. Not known to most of students, but of course, no doubt about it, this is seen in cerebellar diseases. Ipsilateral deafness usually occurs due to some pathology in the ear, maybe outer ear, maybe middle or inner ear. And the unilateral hearing loss, other than the ear, it may be the most common cause is acoustic neuromas. Okay, and classically it arises from vestibular portion of the cranial 8th cranial nerve. And temporal lobe tumor usually does not lead to a deafness. Okay, maybe ipsilateral or maybe contralateral deafness is not a feature of temporal lobe. Golden line to remember: a lesion in the temporal lobe affect Meyer loop of the optic radiation. It causes a contralateral superior homonymous quadrantopia. And just to add on to you, if the lesion lies in the occipital lobe, that is known as cortical blindness. Why? The reason being, the ultimate end point of the vision is in the occipital lobe. You can keep your hand at the back. This is the occipital area. Yeah, it is the place your vision, what you are watching me and I am watching you, is all is seen via eyes, via optic nerve, and the message go to occipital lobe. This is so-called eye center is occipital lobe. And any patient who has a lesion in the occipital lobe, that will lead to cortical blindness. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine. There are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these three things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These three are complete in all the aspects. For more detail, you can contact at this number. It's a for mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.